Hi everyone. We're starting off today with dermatological issues in the aging foot. We all age, and I think aging is a way of life. And after your feet have carried you millions of kilometers through your life, they can eventually wear down. But there are ways to keep your feet healthy as you age. Proper maintenance, care, and regular checkups help. What happens to your feet as they age? As you age, you can lose cushioning and soft tissue fat in the pads of your heels, the balls of your feet, and near your toes. Like the skin on your face, there is also loss of elasticity in the skin on your feet, making it thin and vulnerable. Bone deformities, such as bunions and arthritis, and difficulties undertaking basic foot care lead to foot health issues, and sometimes an increased risk of falls, which may have drastic consequences. Nails also become more brittle, thicker, harder, making them difficult to trim and are prone to ingrowing toenails, fungal breakouts, and other infections. So we have a cartoon here, and there is a lovely lady of an elephant origin sitting there saying, "Size what? I'm 96. I don't believe it. I've always worn size 82. And that's a very interesting and probably a very relevant fact. We change as we get older, literally from head to toe. So as we change, things that we once wore which were comfortable and were our size no longer are. And with feet in particular, this happens because the muscles, which when we were younger were stronger and more conformed and fitted into a particular shape, no longer do so. So muscles relax, joints change, and you widen and lengthen your foot as you get older. So these are some of the changes that you are going to see as you get older. So can foot problems be improved? For older people, most foot problems can be improved by regular maintenance and care. Keeping weight down, shoe modification, and use of cushioned insoles. To undertake regular foot maintenance, some elderly people have difficulties reaching their feet or have bad eyesight. So simple things like cutting nails can be an issue. If this is the case, you can get a family member or to help or to see a podiatrist. If they can cut their own toenails, you've got to make sure that they trim them just short at the ends of the toes using a strong pair of nail clippers. After clipping, smooth the nails with a file or an emery board using a downward stroke. It is also important to have your feet measured frequently as the bones in your feet change with age. This way you can ensure that your shoe fits your feet well and are comfortable. Taking good care of your feet as your age is good for foot health, and it also helps you to stay active and mobile. So the aging process. Well, the aging process is associated with physiological changes, increased incidence of comorbidity, intragenic illnesses, and functional disability. Changes which occur in cardiopulmonary and neurological function, cell-mediated immune and metabolic responses, skeleton and skin structure can create foot problems or affect the treatment of foot conditions. Aging changes in organs, tissues, and cells. Well, thinking about your organs and your tissues and your cells, living tissue is made up of cells. There are many different types of cells, but all have the same basic structure. Tissues are layers of similar cells that perform a specific function. The different kinds of tissues are grouped together to form organs. These are four basic types: connective tissue, epithelial tissue, muscle tissue, and nerve tissue. Connective tissue supports other tissues and binds together. This includes bone, blood, lymph tissue, as well as tissue that gives support and structure to the skin and internal organs. Epithelial tissue provides covering for deeper body layers, the skin and the lining of the passages inside of the body, such as the intestinal system are made up of epithelial tissue. Muscle tissue includes 3 types of tissue: striated muscles, such as those that move the skeleton, also known as voluntary muscle; smooth muscles, also called involuntary muscles, such as those contained in the stomach and other internal organs; cardiac muscle, which makes up the most of the heart wall, also an involuntary muscle. Nerve tissue is made up of nerve cells or neurons and are used to carry messages to and from various parts of the body. The brain, the spinal cord, and peripheral nerves are all made up of nerve tissue. So these changes that occur during aging. Cells are basic building blocks of tissue. All cells experience changes with aging. They become larger and less able to divide and multiply. Among other changes, there is an increase in the pigment and fatty substance inside of the cell, lipids called lipids. Many cells lose their ability to function, or they begin to function abnormally. As aging continues, waste products build up in the tissue. A fatty brown pigment called lipofuscin collects many tissue, as do other fatty substances. Connective tissue changes, become more stiff. This makes the organs, blood vessels, and airways more rigid. Cell membranes change so that many tissues have more trouble getting oxygen and nutrients and removing carbon dioxide and other wastes. Many tissues lose mass. This process is called atrophy. Some tissues become lumpy, which is nodular, or more rigid. Because of cells and tissue changes, your organs also change as you age. Aging organs slowly lose function. Most people do not notice this loss immediately because you really need to use your organs to their fullest ability. Organs have a reserve ability to function beyond the usual need. For example, the heart of a 20-year-old is capable of pumping 10 times the amount of blood that it actually needed to keep the body alive. After the age of 30, an average of 1% of this reserve is lost each year. The biggest changes in organ reserve occur in the heart, lungs, and kidneys. The amount of reserve loss varies between people and between different organs in a single person. The changes appear slowly and over a long period. When an organ is worked harder than usual, it may not be able to increase function. Sudden heart failure or other problems can develop when the body is worked harder than usual. Things that produce an extra workload, body stresses, including illness, medicines, significant life changes, sudden increase in physical demand on the body, such as change in activity or exposure to higher altitude. Loss of reserve also makes it harder to restore balance, equilibrium in the body. Drugs are removed from the body by the kidneys and the liver at a slower rate. Lower doses of medicine may be needed and side effects become more common. Recovery from illnesses is seldom 100%, leading to more and more disability. Side effects of medicine can mimic the symptoms of many diseases, so it can be easy to mistake a drug reaction for an illness. Some medicines have entirely different side effects in the elderly than they do in younger people. So the function. So certain aspects of our body and how our body works have different effects with our circulation, with our movement, and so on. So atherosclerosis and decreased arterial blood oxygenation brings poorer blood flow to our extremities. If there's an impaired renal function, obesity, or sluggish venous circulation, this can cause peripheral edema and slow healing. Decline in immunity is associated with increased vulnerability to infectious agents. So looking at this diagram, aging effects on the vascular system. Through the ages, there are great changes taking place in your arteries. In your 20s, your arteries are generally healthy and clear and obvious of any obvious disease. As research shows, through the aging process, Harm from tobacco, smoke, cholesterol, sedimentary lifestyle can start accumulating. In the 30s and 40s, this accumulation of fatty deposits called plaque typically begin to accelerate in men, and women are generally protected in major arteries until menopause. Though disease may begin in smaller vessels, cholesterol, tobacco smoke, high blood pressure, and high blood sugar and will all cause persistent injury to the inner lining of the arteries. In the 50s, the assault on the inner lining of the arteries continues while the vessel wall becomes stiffer and more fibrous. High blood pressure creates damage apart from the plaque buildup, which makes arteries less elastic or compliant, increasing the workload of the heart. Injured tissues become scarred and calcified. For women to develop 10 to 15 years later than for men, the accumulation of plaques begin to accelerate. So as you see that diagram, you can see in the early 20s, the wall looks quite well, your vessels are great. 30s, the thickening takes place. In your 40s, there's plaque formation and inflammation present. Calcium build-up in your 50s, stiffening of the walls, so the movement is more rigid, so blood flow isn't as good, eventually leading to a rupture, which can then lead to a clot and can then effectively go into your heart or into your brain, causing heart failure. For patients, we often will see in the clinical setting them talking about things like intermittent claudication, pain in the calves of their legs. So they often will say to you, I can walk a certain amount, but then I have to stop because my back of my leg really hurts and it cramps and it causes pain. Breast pain. This is another problem which is seen in the elderly when there is a problem with circulation. They find that they get to a point and when they're resting, the blood pools and therefore causes them to have pain. So they need to move around and shift a little bit so they can be better. Loss of hair. Obviously, we know the blood supplies nutrients around the body, and to hair follicles and so on. You will find that you lose the hairing on your skin that is present there as well. Skin color and temperature changes. Again, as the flow of blood changes, you'll see different presentation on the skin. The skin will not look as healthy or vibrant. It will look more sallow and dark. You'll see pigmentation from the blood onto the surface of the skin. You will see color changes. Skin becomes slightly more bluer. This also would lead then to impaired wound healing of the skin as well. So the effects on venous system, well, think about the biggest muscle pump, blood pump in your body, which is in your calf. There is two giant muscles, one called gastrocnemius, one called soleus. And gastroc is a working muscle. It's a strong muscle, which is powerful and can only work in short bursts. Soleus is a muscle which has lots of little fibers, which is constantly firing. But the two together help us aid the return of blood flow from our lower extremities back into our heart. And often what happens when there is changing in your blood supply, the valves in the veins start to become incompetent. So what takes place is you take a step and then blood shoots from your extremities back to your heart. But if, for instance, your muscles in your legs aren't working efficiently, then that pressure is not achieved. You're not able to shoot the blood back up to your heart. The other common problem is problems with the valves. And now, if the valves become incompetent, each time blood shoots up the limb, the valve behind it then closes. This is to stop the fluid and the blood coming down to where it started from. So these whole segmented areas throughout your limb return blood back to your heart. But if these valves are incompetent, they just fall, which means you get a pooling of blood in your lower limb and blood is not sufficient enough. This eventually leads to a localized tightness or clotting within the limb. It also leads to a breakdown of the skin, which it means that you're prone to having ulceration and wound present in the lower limb. So with the circulation being effective, what does this do to the skin? So aging also affects responses to inflammation and wound healing. And so these start to proceed more slowly. Thinning of the skin occurs as the rate of cell production slows in the epidermis. The dermis becomes thinner and more papery, with fewer elastin fibers, increasing the risk of injury and bacterial skin entry. Loss of subcutaneous fat reduces padding with bone protrudences and more prominent and subject to trauma in the feet. Metabolic impairment results in slower healing process of higher risk of infection in the skin lesions affecting the feet, and impairment in memory, loss of concentration, impairment in focus and judgment can affect personal foot care and awareness of the patient, may be incapable of giving accurate clinical history. So, aging changes in the skin. Well, skin changes are among the most viable skin signs of aging. Evidence of increasing age includes wrinkles and sagging skin, whitening or greying of the hair, or another obvious sign of aging. Your skin does many things. It contains nerve receptors that allow you to feel and touch pain and pressure. It helps control fluid and electrolyte balance, helps to control your body's temperature, protect you from the environment. Although skin has many layers, it is generally divided into three main parts. The outer part, the epidermis, containing skin cells, pigment and proteins. The middle part, the dermis, contains blood vessels, nerves, hair follicles and oil glands. The dermis provides nutrients to the epidermis. The inner layer under the dermis, the subcutaneous layer, contains sweat glands, some hair follicles, blood vessels and fat. Each layer also contains connective tissue with collagen fibers to give support and elastin fibers to provide flexibility and strength. Aging changes in the skin. With aging, the outer skin layer, the epidermis, thins. Even though the number of cell layers remain unchanged, the number of pigment-containing cells, melanocytes, decrease. The remaining melanocytes increase in size. Aging skin looks thinner, paler, and clear, or translucent. Large pigmented spots, including H spots, liver spots, or lentigo, may appear in sun-exposed areas. Changes in the connective tissue reduce the skin's elasticity. This is known as elastosis. It is more noticeable in sun-exposed area or solar lactosis. Lactosis produces the leathery, water-beaten appearance common to farmers, sailors, and others who spend a large amount of time outdoors. So if you imagine, if you're like me, a keen cricketer, and I'm out all day long, you will always find that leathery feeling on the back of your neck because the sun has been baking on you throughout the day. The blood vessels and dermis become more fragile. This leads to bruising, bleeding under the skin, called senile purpura or cherry angiomas, and similar conditions. Sebaceous glands produce less oil as you age. Men experience a minimal decrease, often after the age of 80. Women generally produce less oil beginning after menopause. This can make it harder to keep the skin moist, resulting in dryness and itchiness. Subcutaneous fat layer thins, so it has less insulation and padding. This increases your risk of skin injury and reduces your ability to maintain the body's temperature. Because you have less natural insulation, you get hypothermia in cold weather. Not so common here in Australia, but definitely more in Europe and in Northern America. The sweat glands produce less sweat. This makes it harder to keep cool. The risk of overheating or developing Heat stroke increases. The growth such as skin tags, warts, rough patches, keratosis and other blemishes are more common in older people. Effect of these changes. As you age, you are at increased risk of skin injury. Your skin is thinner, more fragile, and you lose protective fat layers. You also may be less able to sense touch, pressure, vibration, heat, and cold. Rubbing or pulling on the skin can cause skin tears. Fragile blood vessels can break easily. Bruises, flat collection of blood, purpura, and raised collection of blood, hematomas, may form after even a minor injury. Pressure ulcers can be caused by skin changes, loss of fat layers, reduced activity, poor nutrition, and illness. Sores are often easily seen on the outside surface of the forearms, but they can also be anywhere in the body. Aging skin repairs itself more slowly than younger skin. Wound healing may be up to 4 times slower. This contributes to the pressure ulcers infection. Diabetes, blood vessel changes, lowered immunity, and other factors also affect healing. So the commonest problems you expect. So skin disorders are common among older people. That is often hard to tell normal changes from those related to the disorder. More than 90% of the older person have some type of skin disorder. So skin disorders can be caused by many conditions, including blood vessel diseases such as atherosclerosis, diabetes, heart disease, liver disease, nutritional deficiencies, obesity, reaction to medicine, and stress. Aging effect on the skin. So as we've said, you get thinning of the skin, lower oil secretion, dry, itchy skin, pigmentation changes, reduced strength, and reduced elasticity. So with these photos, you can see these common changes taking place. You can see on the heel on the top photo, there is cracking and fissuring present, lacking moisture, so the cracks form in the skin. The dryness is present in the skin. The second photo down on your left, you see the changes of circulation on the skin. So you see this effect of the pigment hemosiderin causing these patches in the skin. The colouring of the skin changes. Vascularly, it looks dingy and dull. It's not vibrant, it's not healthy, it's not strong. Next to it, on the right, we have a foot ulcer. The skin is broken down. There is edema around the area. There's signs of dryness and infection present. The last photo, again, pressure points on the apex of the toe, leading to a breakdown. The skin is very thin. Viability is not good. Therefore, any pressure leads to a pressure sore, which eventually breaks down and causes an ulcer formation. So that's what happens. So we've moved from what's happening with the blood flow through the body. We've looked at what it's done to the skin. And now we move on to the joints, the bones and the muscles. Changes in posture and gait, walking patterns, are common with aging. Changes in skin and hair are also common. The skeleton provides support to the structure of the body. Joints of the area where the bones come together, they allow the skeleton to be flexible for the movement. In a joint, bones do not directly contact each other. Instead, they are cushioned by cartilage in the joint, synovial membrane around the joint, and fluid. Muscles provide a force and strength to move the body. Coordination is directed by the brain, but is affected by changes in the muscles and the joints. Changes in the muscles, joints, and bones affect posture and walk, and lead to weakness and slowed movement. So aging changes in bones. People lose bone mass or density as they age, especially women after menopause. The bones lose calcium and other minerals. The spine is particularly made up of bones called vertebrae. Between each of these bones is a gel-like cushion called a disc. The middle of the body trunk becomes shorter as the discs gradually lose fluid and become thinner. Vertebrae also lose some of their mineral content, making each bone thinner. The spinal column becomes curved and compressed, packed together. Bone spurs caused by aging and overall use of spine may form on the vertebrae. The foot arches become less pronounced, contributing to a slight loss of height. The long bones of the arms and the legs are more brittle because of the mineral loss, but they do not change length. This makes the arms and legs look longer when compared to the shortened trunk. The joints become stiffer and less flexible. Fluid in the joints may decrease and the cartilage may begin to rub together and wear away. Minerals may deposit in and around some of the joint, known as calcification. This is common in the shoulder. Hip and knee joints may begin to lose cartilage, which are degenerative changes. The finger joints lose cartilage and the bones thicken slightly. Finger joints changes are more common in women. These changes may be inherited. Lean body mass decreases. This decrease is partly due to the loss of muscle tissue, known as atrophy. The speed and the amount of muscle changes seem to be caused by genes. Muscle changes often begin in their 20s in men and in 40s in their women. Lipofuscin, an age-related pigment, and fat are deposited in muscle tissue. The muscle fibers shrink. Muscle tissue is replaced more slowly. Loss of muscle tissue may be replaced with tough fibrous tissue. This is notable in the hands, which may look thin and bony. Muscles are less toned and less able to contract because of changes in the muscle tissue and the normal aging changes in the nervous system. Muscles may become rigid with age and lose tone even with regular exercise. So what are these effects on changes? Bones become more brittle, may break more easily. Overall height decreases, mainly because of the trunk and spine shortening. Breakdown of the joints may lead to inflammation, pain, stiffness, and deformity of joint. Changes affect almost all older people. These changes range from minor stiffness to severe arthritis. I'll stop there to say it's very important to think about wearing and tearing. Often when people come and see us, we use jargons like arthritis. And for some people, they don't understand that as a type of wear and tear. So to them, they think they have some form of a very chronic disease. So often to explain things like osteoarthritis, it's easier to say it's your body's way of wear and tear. Now, I myself, as I said earlier, am a cricketer, and through my cricketing life and keeping, I have broken, I don't know if you can see it, every finger on my right hand compared to my left hand. So as I have aged, the wear and tear in this hand is different to this hand. I get more aches and pains in joints. So when you have an injury and things wear down, you will find you get osteoarthritic changes, which then will lead later on into life to osteoarthritis. But that is the body's normal wear and tear, except when you have an injury that accelerates that process. So back to this, the posture may become more stooped, bent, the knees and hips may become more flexed, the neck may tilt and the shoulders may narrow while the pelvis becomes wider. Movement slows down and becomes limited. The walking pattern becomes slower and shorter. Walking may become unsteady. There is less arm swinging. Older people will get tired more easily and there's less energy for them. Strength and endurance will change. Loss of muscle mass reduces the strength. So common problems associated with this. Well, osteoporosis is probably the most common problem, especially in the older woman. Bones break more easily. Compression fractures of the vertebrae cause pain and reduce mobility. Muscle weakness contributes to fatigue, weakness, and reduced activity tolerance. Joint problems ranging from mild stiffness and debilitating arthritis, as in osteoarthritis, become more common. The risk of injury increases because the gait changes, instability and loss of balance may lead to falls. Some older people have reduced flexes. This often caused by changes in the muscle and tendons rather than changes in the nerve. Decreased knee jerk or ankle jerk can occur. Some changes, such as positive Babinski's reflex, are not normal part of aging. Involuntary movements, muscle tremors, fine movements called fasciculations are more common in older people. Older people are not active, may have weakness or abnormal sensation called paresis. People who are unable to move on their own or who do not stretch their muscles with exercise may get muscle contractures. So the bone, in simple terms, bone formation is affected by the reduction of osteoblasts, differentiation, activity, lifespan, and increased osteoclast activity. Resultant osteoporosis can bring fracture and bone thinning, which can affect the skeletal structure alters with intervertebral disc flattening, cartilage changes, spinal shortening, and a loss of elasticity in tendons, bringing flattening of the feet and foot spread. This results in new pressure points and results in bunions and callosities. Now, as we're talking about osteoporosis and demineralization of bones, it's very important in practice that you will probably be one of the first people to detect this change that's happening in your patient's bones. And sometimes it's not as obvious as you think. They haven't had a fracture yet, they haven't had a problem. For me, in my practice, I see a lot of patients who have a lot of severe bone pain. And I mean this in the feet. So they're not your typical, I dropped something on my foot, or I ran a marathon today, or I basically kicked something. It's often something which has slowly been coming along. So they'll say, I've had this pain, it niggled and now it's got worse and it just keeps going. It's a deep pain, it's in the bone. And they probably would have had already used painkillers, had certain types of ointments, anti-inflammatories that they've applied. They've probably had insoles and supports to deal with their biomechanical issues, but this pain continues. And I find that the interesting thing for me coming from the UK is that there is this very presumptuous thought that if you have bone pain, or if you especially are a woman coming to menopause, that you will have a bone scan carried out or a DEXA scan carried out by your GP. So this is almost accepted, but it often doesn't happen. So part of that interrogation with a patient or questioning is to ask, have you had a bone scan? Because that will pick up what the condition of the bones are. I have often seen in multiple cases where I've asked the question, they've not had a bone scan, and I feel that actually the underlying problem here is that they may be having undiagnosed osteopenia, osteoporosis, is to get them to go to their GP and have this scan done. The other problem is looking at your environment and the climate you live in. Now, we know that calcium is important to the bone, but also we need to address a converting factor, and the converting factor for this is vitamin D. So you can have plenty of calcium, but if you don't have the vitamin D to convert it in the body, you find it's not giving your bones what they need. So often a GP will prescribe them things like a calcium vitamin or a zinc supplement combined together. We have something called CalciTube back in the UK. I'm sure there's something equivalent here. But at the same time, you also have to look at what exposure of sun they're getting. Now, you know, Australia is a hot country. You see a lot of sun, But you've got to remember, you're also blocking out the sun most of the day. You're using high density factors of sunblock, which means you might not be getting enough rays coming through to give you the vitamin D that you need. Also, looking at countries like the United Kingdom, we are probably the highest number of have the highest number of deficiency in vitamin D probably in the world. We don't see much sun, and we're pretty much covered most of the time. But in the same breath, when you go to hot countries like Saudi Arabia, there is quite a lot of vitamin D deficiency there too. And this is, again, more down to the fact that they are covered, and culturally, they don't expose their skin. So they, again, are not getting vitamin D. So very important when looking at these factors and your patient, and whether their condition is a traumatic one, or is it that they are lacking something through their lives or through their aging. So here, bone changes. Here we have a 55, 65 and 75-year-old skeleton. And you can see as the aging process takes place, there's a decrease in osteoblastic activity, there's a decrease in bone volume, and there's a decrease in minerals. And so you can see as the decades go on, this curvature starts to occur. And by the time we hit 75, the trunk is shortened. And as I said earlier, the arms and the leg and the bones there remain pretty much the same. So you almost become almost like an orangutan or a big gorilla. You sort of shorten your trunk and you walk around gingerly to be able to, but of course very slowly. So with this demineralization we talked about and osteoporosis, you find there's this decrease with skeletal volume, height and mass. There's also increased risk of fractures. So here you've got a picture of sort of a normal foot on your left and a foot which has got a fracture. And you look at that fourth metatarsal shaft, you can see the bone just below the head of the met being slightly ajar. And that's very common because the bone is weak. Any degree of a fall or trauma or walking impact, this causes fracture. So it's very important to understand where this has come from. So with the bone, we know we've looked at, there's the aging aspect, there's the menopausal aspect, because you're drier, you're losing key oils in your body. There's local factors, trauma, doing a particular activity, sporadic factors like someone's dropped something onto you, you've had an accident which then caused a problem. I have a very interesting story I'd like to share with you about fractures, and it doesn't necessarily mean being old is only a time when you can have fractures. We used to have a very dear PA to my father many moons ago, who was of the age of mid-70s. And this dear lady was walking from the back garden back into the house when she slipped and she broke her femur. Now, in that age group, having a fall and then having a break like she did is common, but also quite fatal. Anyhow, this dear woman, who obviously at the time had lived through the war, was very strong individual, had very little wrong with her. She was in plaster. 3 months later, she was back to normal, back healed perfectly well and walking. But 1 week later, she fell exactly in the same place again and broke the same femur again. So again, we're thinking, oh my God, this could be fatal, because, you know, your main arteries, blood flow through your leg, through your femur, it is damaged. Again, 3 months later, she was fine, and still after that had no problems. So yes, it is important that we look at the elderly and the structure of our bones. But actually some people, whether it's a genetic predisposition or their well-being or what they eat or what their nutritional supplements are, they can actually have quite strong levels of improvement. So those are all things to sort of address and look into. So advice, increase physical activity. So you want to be active. As you're getting older, things are slowing down. We've talked about that. We've talked about the joints are not as active. So moving them, getting that flow of blood, fall preventions, and getting them to understand what they can and can't do. Not leaving wires around on the floor or plugs, not leaving something that they can trip over, wearing things which fit their feet so they don't trip over. Look at their environment, have panic alarms so they have people that they can contact. Awareness of fracture risks, as I said, making sure minerals are right, make sure that they've been seen and had a bone scan and so on. Patient-reported diagnosis. So take on board what that medical history has been given to you. Look at the short stature, kyphosis, lordosis. Kyphosis and lordosis is curvature of the spine. So kyphosis is generally an abnormal, excessive curvature of the spine, normally the thoracic sacral spine, whereas lordosis is a inverted curvature leading of the area of the sacrum and the lumbar and cervical regions. So, and then treatment address the insufficiencies and the stress fractures. So joints. So we know cartilage degeneration, decreasing the integrity of the collagen matrix, water content, increased synovial membrane and synovial fluid. So you can see in the diagrams, you have early stage of disease, late stages of disease. Early changes, there's a degeneration of the cartilage around the bone and reactive new bone being created. As the disease process occurs and aging occurs, that cartilage particle has changed. There's loss of the cartilage, so the joints are coming closer together, and then there's bone hypertrophy. So you also find cartilage degeneration. There's an increased risk of osteoarthritis, pain and stiffness and deformity, a decrease in range of movement and joint displacement, increase of risk of falls, and really, as you see with a picture, you can see the cartilage has gone, and the white area in that picture is cartilage. So it makes you start appreciating how to manage these patients. Pain is going to be a problem for them. Pain relief, recommending pain relief. Obviously, things that are over the counter which they can use are fine to recommend in the first instance, but obviously sending them back to their GPs to make sure their pain relief is addressed. Accommodate the deformities, so depending on what joints are affected, see where you can help with stopping them overloading and causing pressure. We've talked about things like supports, orthotics, insoles to stop overloading, and then referral to orthopedics. Different sorts of measures can be taken. They can put a camera into the joints and to evaluate any synovial fluid or bits of bone that might be around that can be cleared out, or requirement of knee surgery or joint surgeries. So the aging effect on bones and joints, you get decreased bone mineral density, joint space narrowing, loss of articular cartilage, osteophyte formation, a deformity, and reduce and loss of function. So you can see with all these changes that are taking place, especially when you look at the last two photos of the joint, of seeing the hallux valgus, the bunion, and seeing the x-ray, and you can see how much that toes almost are blocked. It's completely come off with very minimal attachment of the phalanx to the head of the metatarsal. And in fact, it is pretty much fused. It's an osteoarthritic toe. But that, of course, means functionality of the foot and the anatomy has greatly changed. Now, these photos are really a good thing for you to visualize, to understand everything we're talking about aging. Now, if you start at the top, and we'll work our way down on these photographs, you can see, if you look at yourself when you come out of the shower in a full-length mirror, and you look at your legs, and you look at your skin, and you look at your nails, and you look at your joints, you will find that you're probably reasonably toned. The muscles are balanced and they are strong. When you look at this individual, you can see right just below where the t-shirt finishes in the inner thighs, you can see the skin is sagging. You can also see everything is collapsing. It's no longer viable. The tissue hasn't got the viability. It needs to be strong. As we go down towards the knees, you can actually see the knee joints. They're knobbly and they're not facing straight. They're at an angle. And as we go down the limb, you can see the changes that are happening on the legs. You can see the shins. You can see the colour changes. This is a sign that there is poor circulation taking place. It also shows biomechanically there is a change in how the walking cycle is. You can see when we reach the feet, the arches are completely collapsed. They're completely flat, a term known as pes plana valgus. You can see that they have bunions, so that you can see they overpronate when they walk. You can see that their big toes, due to the bunions being present, have meant that those toes have shot up and are impacting all with their shoes. You can actually see the tips of their toes are red where they've been bouncing. You can see the hammering of the second toes and the clawing of the lesser toes. And you can see that everything is not as it should be. And if you imagine the lack of viability here, you should also think about trying to walk. How is that person going to walk? It's not going to be efficient. So we're seeing the decreased muscle mass. We're seeing decreased muscle strength, flexion deformities, atrophy of the interossei, muscle digital deformities there. So these changes take place within the foot. And one of the things that we often notice through aging and time is changes in the Achilles tendon. And something which is quite common called Achilles tendinopathy, a thickening of the Achilles tendon, happens due to ongoing trauma through the ages. Now, let's think about biomechanics and walking and how we walk. If you think that as we are growing older, depending on what type of footwear we wear, has an influence on how the structure and the anatomy of muscles coming from our legs into our feet are affected. Now, if, for argument's sake, when we are young, we like wearing fashionable shoes with a bit of a heel, say more than 2 inches, and we wear them every day, that's not a normal position for our foot to work anatomically. So that means wearing that causes a shortening of that Achilles tendon. So as the ages go by and you've done and worn these types of shoes on a regular basis for 20, 30 years, we get more sensible as we get older. And we think, oh, I know, we're going to not wear high heel shoes because that's a silly thing to do. We're going to wear more stable flat shoes. So suddenly, over the 20, 30 years, the Achilles tendon hasn't really worked too much. It's shortened. And now suddenly you're putting a person into a very flat shoe where there's no heel, so that when the foot contacts the ground, the Achilles can't take the stress from this flattening, and it ruptures and it becomes inflamed, and then it becomes hard. And you get beginnings of these Achilles tendinopathies. And often you may well see in the elderly, as they walk barefooted, they can't actually put their heel to the ground. They walk on tippy toes. And so a little heel helps. Otherwise, it's very difficult to move. And of course, that muscle bulk, this Achilles tendon, becomes part of those muscles in your calf, where your big muscle pump is. So they get intermittent claudication, they get cramps, they get pain, and they then have real difficulties to move on and walk. So that's some of the changes that are taking place. Now, there's then an effect on all the soft tissue. Now, going back to the fundamentals of biomechanics and actually to the day we're born, if you look at how we're born flat-footed. So up to the age of 6, we waddle like ducks. And because we waddle like ducks, there is no problem with what footwear we wear and the weight we carry. But when we reach the age of 6, there is a big valgus change. So at the age of 6, our heel bones rotate out and they bring up our arches. Now, in 9 out of 10 people in the world, this change doesn't happen fully. It doesn't go to it doesn't go to neutral or 0 degrees. It still remains 3 degrees inverted, which means when we walk, there is a different change to our walking cycle. Think of the gait cycle for a moment. Your heel contacts the ground. You then have mid-stance, where it's a compact unit of all your bones, your metatarsals and tarsal bones, and then you rock forward, and then you drop your 5th, 4th, 3rd, 2nd, and 1st. And then at the hallux, you're pronating to a point of toeing off, where everything becomes rigid or supinate to push off. That's the rocking cycle of how we walk. But if you imagine 90% of the population, their heel hits the ground, but the subtalar joint isn't neutral, so it rotates inwards. This leads to an unlocking effect of the mid-tarsal joint. So suddenly this uniform structure, which was compact, is like a bag of loose bones going in every direction. So suddenly at mid-stance, you've collapsed the foot. So as you can see in that picture on the right, the forefoot widens, and you can see that it's splaying of the outer borders. You're also increasing the pressure in the ball of the foot, and this leads to an effect of the fibrofatty padding. Now, that fibrofatty pattern is there for a very important purpose. It's shock absorption. Because underneath there, you have your heads of your metatarsals, you have blood vessels, nerve endings, ligaments, and so on. And as you put too much pressure on that area, there's a displacement of that fat tissue, and it starts sitting underneath your webbing of your toes. It then exposes those metatarsal heads. And so this causes an increase in pressure on the bones, which causes a localized inflammation and pain. But it also means the structures there, like the nerve endings and blood vessels, get compromised. So suddenly you'll experience things like shooting, burning pain, which are nerve damage or digital neuritis, leading to things like neuromas. As we progress and we continue to move on through our gait cycle, that dropping leads to this splaying effect, but it then also means we're not toeing off as we should. In fact, the weight is inverted onto the first ray and the first metatarsal ray. And so as you overpronate at this point, you suddenly find your full body weight isn't transferring in this rocking fashion, but actually inverting and dropping inward. So you're rolling your foot. And that rolling actually means you start to put the pressure onto that first MP joint, and the beginnings of a bunion arises. And anatomically, when you look at that first ray and the first MPJ, your foot collapses and that big toe joint rolls. We already have talked about what's there. You've got the 2 joints, you've got a sac of fluid, synovial fluid, cartilage on the surface. So that pressure, the body can't cope. It lays down this fluid, so the joint capsule inflames, and that's called a bursitis inflammation. You then have an anatomical change on structure because the big toe joint has muscles and ligaments which hold it straight, like a bowstring effect. They pull above and below. That moves over, and so that moving over means you get this valgus deformity. But that's not the half of it. This then leads to other problems as it's moving along. So there's a rotation of the big toe joint, and as you can see in that picture, the second picture, the toenail is now facing towards us. It's basically rotated. And as this is rotated, it means the sulci around the nail is now taking the full weight and pressure when we push off. So the skin takes the weight and pressure, which causes a curvature of the nail, leading to things like ingrained toenails and involuted toenails. And again, the toenail itself will cause friction on the front of the shoe, causing thickening and breaking of the area. And then the second toe, due to the space being taken by the hallux, leads to a hammering of the toe. So it lifts up and above. This then causes the top of the IPJ to rub in the shoe because the space is now being restricted and it's touching the top of the shoe when you walk, causing the formation of a corn. And on the apex of the toe, the same thing happens as well. And of course, we've already talked about the circulation to poor. This will then break down and cause ulcerations and wounds. The lesser toes then become clawed because of the space present and changes because of the hallux. And that in their own right will start causing callus formations on the apex and on the dorsum of their feet. So you can see how one simple little biomechanical instability can lead to many, many problems. In fact, fundamentally lead to problems across every aspect of our skin, nails and bones. And aging makes this worse because that viability that the structure, our subtalar joint has, is lost. So it's easier for it to just decrease and therefore injury to occur. So, as I said, walking on particular areas, especially the ball of the foot, this changing means that there is an increase of inflammation, and that in its own right will cause pain. And then your body protects itself, so it lays down keratin, so you get the callus formation present. Now, a patient may well come up to you and say to you something like, oh, I feel like I'm walking on pebbles. And this is a sign of certain disease processes. We know with rheumatic disease processes, such as rheumatoid arthritis, one of the first things is this inflammation that we get around the bone. So it's not just due to trauma, but actually an autoimmune process taking place. Therefore, the area is stressed and this skin change takes place and the inflammation then occurs. And when you look at these different graphs, you can actually see the immense pressure on the heel and the ball of the foot that is occurring when this is happening. So at the age of 70 years, 30% of people have impairment of their vision. And this affects their ability to carry out personal foot care. Neuropathy diminishes their awareness of pain sensation in peripheral extremities. Tenderness and pain may not be experienced. We see neuropathy as an aging problem, but we also see it in a diabetic problem. So someone who already has diabetes at an early age and has a peripheral neuropathy, this will be more extreme as they get older. Immobility is not commensurate with aging, but many older people lose suppleness and mobility. They fail to exercise the lower limbs, and posture fixation impairs circulation of their feet, and poor balance and impaired proprioception can result in foot trauma. So chronic morbidity. Chronic morbidity may impinge upon foot health and management. Cardiac coronary insufficiency may impair blood flow with cyanosis to feet. Starve oxygenated blood, resulting in delayed healing and poorer skin protection. Stroke disease can affect the limbs, alter balance and walking, and bring changed demand on feet and impaired function. Lung conditions can reduce oxygenation and impair peripheral tissue response to infection in the feet. So medication. Routine medication can cause peripheral edema, impairment of peripheral circulation, or affect immunity and healing. For instance, steroid preparations reduce immunity and increase the risk of infection. Anti-clotting agents can increase bleeding time, a consideration for podiatrists when wielding a scalpel. Podiatric anti-infective and antifungal agents can react adversely with conventional systemic drugs. Management consideration. Well, the aged foot needs individualized care response based on risk assessment. So clinical history and current and past illnesses. So I said this before, taking a history of your patients as holistically as you can is probably very important. I know they may come in just with toenail problem or a little corn on their toe, and they may appear to be well. Often the biggest problem with taking clinical history is you find when you ask a patient what's wrong with them, they say nothing. But then you ask other questions and you look at a referral letter, or you look at a questionnaire that they may have filled in, you actually then discover they've got cholesterol, they've got hypertension, high blood pressure, and so on. Because it's a perception when you're talking to someone for them to say, I'm okay, unless they are very, very sick or ill. So in their well-being state, it is that they are fine, but actually they have these comorbidities which are there, which need to be addressed. It's also important to understand the patient's capability and mental status. As we age, we may be able to talk very well, but our bodies may not be able to reach our feet. So they may not be able to carry out simple basic hygiene. They may not be able to cut their nails, and they may not be able to put creams on and lotions on. So it's important for us to have an understanding of their state. The other thing that's also possible is things like dementia, early signs of dementia, and forgetfulness, because you may tell them something, and if you've told them something and it's too much for them to process, it's not there. But sometimes there is the beginning of change. So it's understanding and realizing what's going on. Concurrent medications. So look, as we get older, there are multiple drugs our patients will be taking. In fact, they will come with a cocktail of drugs every time. It's very important that when a patient comes to see you, you want to focus on them bringing their drugs that they're currently taking with them. And this is important because they won't remember what they're called because they've all got very complicated names. And if you have them, you can actually see what their dose they are and what they're taking. And some of these risk factors are, as I said earlier, if you're on a cocktail of drugs, they can often mimic a disease. So you think you've got one thing when actually something else is going on due to a side effect of the drug. And sometimes they're contraindicated. If you discover something like this, the first thing actually to do is send them back to the GP. But at the same time, get them to see their pharmacist. Pharmacists are the best drug analysis people there. They understand the drug, they understand the contraindication better than the doctors. Therefore, having them review the current status is a better way of being able to get a change in their drug plan. Examination of the feet and lower legs. You should all be able to do this quite comprehensively now. Examination of feet, looking at colour, texture, looking at neurological, looking at blood flow, pulses. They're essential throughout, getting a clear understanding of what's there. Potential side effects of treatments, we've just talked about. Special attention to diabetics, autoimmune disorders, those on steroids and anticoagulants. As we know, all the more systemic related problems and those things that have been around for a long time or have had accelerated effects on the lower limbs and on feet and structure. So addressing them and making sure you look more carefully at those areas are important. So foot examination. So when examining the foot, always look at the skin colour. You want to, as I've mentioned already today, colour is so important. The more darker, dingier looking skin tones, normally an indication of something lacking, normally circulation. You'll see more in older patients when they come in literally bluish feet, and that's obviously a sign of things going on with the heart and atherosclerosis, narrowing of blood flow. So look at the blood and the skin colour and texture and tone. Look at temperature, back of the hand, feel if the temperature is the same all the way from the tip of the distal aspect of the toe up to the ankle. See if the temperature is hot or cold. See if it's even all the way through. The state of the toes. Look at is the skin atrophic, anhydrotic. Look at capillary refilling time. See how slow the flow of blood is or how quick the flow of blood. Is there pooling? Look into interdigital clefts. So often we miss things because, especially with people getting older and being in care homes, often hygiene is a big problem, and you will often find things living and growing in between clefts of toes. Examine the tendons and the joints and foot disorders and disease. It should also assess whether there is vascular ischemia or a generalized condition involved. Has the longitudinal transverse arch of the foot been lost, and is there abnormal skin thickening at pressure points in the soles of the feet? Other questions include, is there a skin infection? Are there callosities, corns, bunions, hallux disorders? Is the pain on moving the toes, flexing the foot? Is the walking gait normal? Are problems with flexion, extension, ankle? Is there tendinitis? Now, these are all simple things that you don't need any equipment to do. You can do relatively quickly yourself in a few minutes, and can take a point of a baseline. But at the same time, as I've said the last 2 weeks, you've got cameras, you've got camera phones. Take a picture. It's always brilliant for your record to take that first picture of what is that patient's foot looking like today, because you know they'll come and see you in 6 weeks, 8 weeks time, and that could have changed. And to actually, you won't clearly remember what it was, but having a photographic evidence helps. So foot disorders can affect the skin, and this can be local due to trauma, bacterial, fungal infection. It can also be systemic, and it can be due to atherosclerosis disease, soft tissue, pressure of nails, shoes, distorted toes, joints causing corns and callosities, damage of the nail plate, onychogryphosis, thickening of the nail, ingrown toenails, bones due to trauma from sometimes from osteoporosis, tendons, often get repetitive strain injury with strains, sprains and small muscle and tendons of the foot, and joints due to gout, osteo and rheumatoid arthritis. So, corns. So we've talked about the structure and the changes that are happening. The biggest thing that's happening as we get older is compensation. The body compensates all the way through. So areas to definitely look for in the podiatric world are things like corns and callosities. We know that corn, hard or soft, cause pain. They interfere with walking. They generally need debridement with enucleation and often require dressings and support. But actually think more clearly what a corn or callus is doing. In many ways, a corn and callus is your body telling itself there is immense pressure at this point, and due to an abnormal gait and an abnormal anatomical position of the bones and structures of the bones, this area is being overloaded. And believe it or not, callus is good, not necessarily bad. So seeing callus and the corns that we're seeing, we must always remember it's your body's way of protecting itself. It's saying there's immense pressure, I'm laying down this hyperkeratosis, and that's for protection. Obviously, when it builds up too much, it then causes pain. So one of the things that you probably will be taught is to debride callus down to until you've got normal skin, which is fine. If you're then going to have a program to deal with the underlying problem and mechanically rebalancing the foot so they don't walk in that area and reform that callus. But that's not always the case. And often, if you debride all the way down, you actually find the callus will come back twice as quickly and will become more sensitive and painful. So often, one of the things to take on board is to underoperate. And underoperating is simple. What you're really doing is leaving a very small slither of that keratin behind. And what that will do, it gives the foot a degree of shock absorption so it doesn't get so rough. And it won't form the callus back as quickly. So, nail disorders. Inadequate trimming of the large toenails often lead to small spikes of nail in the lateral border of the largest nails untrimmed. The nail continues to grow and pierce into the skin edge and cause pain and infection. And then without therapeutic intervention, this will become chronic low-grade sore, and people resort to wearing slippers to alleviate the pain with increased likelihood of resultant falls. So what that's basically saying is we're getting older, can't reach our feet, so we try and have a go at cutting nails. We haven't got the right tools. We've used a pair of scissors. We've left an edge. That edge, as it grows into the flesh. And as we walk, we're putting pressure onto it, which now hurts. So we wear something softer. So the softest thing to wear are our sandals or our slippers, which generally are big and bulky, very roomy, but you have to grip, which then means as you grip, you lose balance and it's easy to fall, and then you've got a fall injury. So something as simple as a very little nail condition can be quite detrimental in an elderly individual. Nail thickening. Onychogryphosis can lead to walking difficulties if untreated. Damage to the nail plate from repeated hitting on the large toenail or the shoe obstruction can result in overgrowth of the nail and with much thickening. The nail is difficult to clip and is often left to elongate and overgrow, and the toe and even undergrow another toe. Nail rasp can thin the nails and cutting them short as close to the end of the toe. Regular foot care is required to keep the overgrowth within toe limits. Nails should be cut transversely across the nail just behind the border of the toe. Angles should be rounded and ensure sharp edges do not embed in the nail border. And if it does infect, can result in paronychia, which can be painful and resist treatment and require nail avulsion. So, aging effects of the nail. Thickening of the nails increase prevalence of fungal infections, trauma of the nail bed and nail pathologies, difficulty in cutting nails, ingrowing toenails, neglect. So you can see that first toenail on the first left, you've got thickening of the nail, you've got a curvature, you've got that area that looks very fungally in its appearance. The nails underneath, you can see a gross onychocryptosis or ingrowing toenail where the nail hasn't been cut properly and has been left to fester. So that grows very quickly. And of course, remember, as soon as an ingrowing nail cuts into your skin, the body's healing itself. It lays down granulation tissue. So you see all of this new tissue trying to trying to heal the wound. But then there is a piece of nail spike, which is basically stopping it from healing. So it overgrows on the outer borders. Equally with nail trauma, the nails thicken, people leave them and can't cut them, or something's been dropped on them, which then leaves them to get thick. As you start your life as a podiatrist, and if you work in care home, aged care facilities, you will find, due to a lot of patient neglect or podiatrists not being seen, patient not being seen by podiatrists for months on end, you actually find their nails will grow like this. So this is very, very common picture that you will see. So nail cutting, I think it's pretty straightforward. On average, we would say 6 to 8 weeks is how you should, how often you should have your nails cut. You should cut straight across. Obviously, when we say that, we mean that not in a straight line straight across, but in the way the shape of your nail is and your toe is. Emery boards and files to take off rough edges. If you can't cut your own, if the patient can't cut their own nails, then see a podiatrist or find a relative. Preferably not in an elderly couple where you'll find, one of them is 80 something and the other is 70 something, and they barely can't look after each other. You want to make sure it's a young individual that can help, or someone who is able or competent to be able to do this for them. So these are sort of pictures of good and bad ways of cutting nails. First one being too short, exposing the tip of the toe. Rounded, not so bad, but because of the way it's rounded into the flesh, this will cause involution of the toenail. V-shape, never a good idea. And the proper cut is how it should look. So nail and web infections. So tinea infection of the interdigital toe clefts are common and may result in tinea infection affecting most of the feet. Untreated bacterial infection often supersedes the bacterial, the fungal infection. In diabetics, this can be a serious consequence. Funguses can cause chronic infection in onychomycotic resistant to treatment. Poor foot hygiene encourages growth and failure to dry the webs of the toes after washing. Washing helps maintain their presence, which sometimes spreads to the remainder of the foot. The fungus can spread to the nail and gradually discolor and destroy it. Affected nails often become brown, crumbly, erode away, or can also be onycholysis, where there is a lifting of the nail. Elderly people have toenails, often will have toenails infected. So here we can see the first two both showing athlete's foot, but actually completely different presentation. Obviously the top one is more macerated tissue, that's why you have that whitish appearance. Here we've got more dryness of the skin, so the cracking is due to that. And then secondary infection, so you can see this beautiful coloured Pseudomonas, which is this common when infection is in place. You also see it in wound infections, in ulcers. So treatments, so antifungal treatment is often prolonged. Oral medication may be required, but it can have effects on your liver, which is hazardous to the old. It can be contraindicated. Antifungal can be used reasonably easily, but not always super effective. Scraping from the nails and infected skin can be taken to be cultured to see, to form a diagnosis in resistant infections. Diabetic patients are particularly likely to have lineal infections affecting feet and toe webs. These respond to treatments like antibiotic creams. Scratching the skin breaks down, skin breakdown can create ulcers that heal very slowly, and then poorly controlled diabetics may develop neuropathic ulcers of the toe that usually are painless but dangerous and need a prompt amputation. So, toe deformities. Hallux valgus usually results due to wearing high-heeled shoes. Results of the big toe being displaced inward to override nearby toes with marked deformity. This results in callosities of the callosities, corn, skin abrasions and ulcers. Appropriate foam padding to take pressure, the deformity, and wide-fronted shoes can alleviate this problem, which often associated with a bunion. Lax tendon and arthritis brings joint disturbances with protruding joints of the small foot bones and misshaping of the foot and the toes and the bunions. The latter causes much misery and often prevents wearing of conventional footwear and recourse of hazardous soft slippers. Bunions are swellings of the joint between the great toe and the first met bone caused by ill-fitting shoes. Protective padding of anti-inflammatory ointments and wider-toed shoes can improve comfort and reduce pain, but sometimes only surgery can improve symptoms. A bursa may develop over the bunion to add to discomfort and deformity and increase the shoe pressure further. Additional padding is required to give time for the unwanted fluid to be reabsorbed. So looking at bunions, you can see with the picture first on your left, the redness around the joint. This is an initial area where the bunion is becoming inflamed. As I mentioned, around the joint you have synovial fluid and that will often get red, and this is a bursa formation. The second picture shows you the bunion moving on. So you've now got pronounced prominence on the medial head of the metatarsal with a deviation of the bone more away from the midline of the body, and you can see the clawing of the second toe. And you can see with the schematic what changes are taking place and how that bone no longer is in line, it's starting to become slightly more subluxed. Hallux rigidus is another form of first-ray deformity, and this actually happens a lot with joints which have had trauma to the first metatarsal head, and it's normally thickness, painful, and arthritic. And often it starts off with something called hallux limitus, where there is limited movement. But generally, with the two bones, what is happening is there is a narrowing of the joint space, and the movement of the bones pushing up and down is limited. So they're actually touching each other. So at limiters, they're close by, and the muscles pull and the attachment keep the area of the joint capsule very close to one another. But by rigidus, it is pretty much a fixed toe. So there is no movement, no plantarflexion or dorsiflexion present. And so this has a great impact on walking and in fact, the walking cycle. So in the gait cycle, often an application of a rocker bar sole type shoe is made to able to compensate for the limitation of movement on the first ray. Other first joint problems that are seen are gout, osteoporosis, and rheumatoid arthritis. And gout is quite interesting because it's down to, again, an inflammation of that big toe joint, but actually due to a deposit of uric acid crystals, which form. They often form in other areas, and the lining of the urinary tract is one area. But as you can see from both schematics, there's clear inflammation around the bone. Often people misdiagnose this for osteoarthritis, but actually it is gout. And they can do a blood test to measure the urate crystals, and are given generally an oral anti-inflammatory drug known as alpurinol, which will help. Gout tends to form because of diet, and it's affected by fatty foods like sausages and heavy meats. It used to be known as the port drinker's problem, but again, yes, heavy minerals, heavy red wines and so on, port are a problem. So kind of trying to summarize some of the stuff that we've talked about over the last hour or so. We've got this really good summary table saying what happens with structure and age-related change and the impact. So for bones and joints, osteopenia and osteoarthritis, and the impact is increased risk of fractures, pain, reduced movement in joints and deformities. Fat pad, atrophy of the fat pads, the fat pad depositing around the ankle. The impact is pain under the heel and the forefoot, reduced movement at the ankle. Muscles, reduced muscle mass, reduced muscle strength, impact on gait style. Ligaments, less elastic, stiffer, reduced proprioceptive function, more prone to injury and widening of the forefoot and lowering of the arch. Tendons, change in the tendon structure and collagen, decreased tensile strength, tendinopathy, increased risk of rupture. Skin, thinner, drier, less compliant and resilient, prone to cracking, callus ulceration formation. Nails, thicker, brittle, difficult to cut, more prone to ingrowing toenails, onychomycosis. Arterial system, loss of capillary compliance, changes to resistant atherosclerosis, higher blood pressure, orthostatic hypertension, reduced blood supply, loss of hair, dystrophic nails, pain, impaired healing, ulceration. In the venous system, we get decreased elasticity, less elastic tissue and collagen cross-linking, incompetent valves, backflow, and increased venous pressure. Varicose veins, edema, limited joint movement, hemosiderin deposits, stasis, dermatitis, ulceration, and then neurological system, reduced nerve conduction, decreased sensitization, and loss of nerve sensation. So the foot, how do we manage this? Foot care. So meticulous foot hygiene is important in older people. Feet and toe webs especially should be properly dried after washing. Great care should be taken by individuals, carers, healthcare professionals when cutting toenails or paring corns. Toenails should be regularly cut and not left with edges which are unseen and grow into surrounding skin. Friction points from bunions and displaced toes should be protected from trauma with padding. Debris should be removed regularly from nail borders. Sore and infection of the foot, toes should receive prompt attention. Diabetics should have regular foot surveillance. So to summarise, bunions, corn, callosity, edema, infections of the feet are a burden to older people. Good treatment of aged foot challenges the doctor, nurse and carer. Geriatric assessment should include comprehensive examination of the feet and appropriate remedial therapy. Good management depends upon recognising need, instituting regular examination and treatment. Good personalised foot care can help the old maintain mobility and enhance well-being. So that part ends our talk on aging. Here are a few things I think are quite important, more looking at what tools are out there to help us and help healthcare professionals. So you may come across something known as the clinical practice guidelines through your time as a podiatrist. And these guidelines are set by individuals who have basically looked at a particular area of care. So in here, we're looking at foot problems in the elderly, podiatric assessment and management. I've just recently completed clinical practice guideline for a genetic condition called epidermolysis bullosa, or EB for short. And to design one of these, you have to take a period of time where all the literature in the known world is taken with all the different search engines. Look at the literature that's there and then put it into subgroups, whether they're randomized controlled studies, case studies, anecdotals, case reports, and so on. And then using different sorts of measuring tools, such as SIGN, be able to go through those and be able to analyze how good quality of that research paper is. This then formulates a position for you to help talk about certain areas in question. So with this clinical practice guideline, it's really good as a reference tool. It gives you a scope. It looks at key points and key messages. So its key messages here are: don't forget to carry out clinical examination, identify risk factors, adapt pedicure techniques, educate the patient. What it also does, it sets a guidance to the healthcare profession as well as the patient. So for what role will the GP play in this patient's care for these areas? When should a GP refer to a podiatrist? What should a podiatrist then assess and look at? So carrying out clinical examination before giving a podiatry treatment. All of this mostly is quite straightforward, and we have covered all of this in our lecture already. But these are things to look out for because they're there to help you. They also help you to work out what to do next. What is the protocol if someone comes in and there is a problem? Who do I need to send to? How do I write my letter? What should I do? And giving advice to the patient. Where should they go for further care? What good resources out there for them to be able to go on to help with their problems? So there's a few studies which I have pulled out, which I think are worth a mention. Of course, all of these studies you can look up and go through yourselves. A study done in 2004 by Dunn looked at what the prevalence and impact and association of foot problems in older people. And this was divided into 3 categories. There were over 784 patients that took part. And it looked at the effects of dermatological changes in the feet, orthopedic, and pain and tenderness, and looked between the difference between men and women. And interestingly enough, when you look at things like thickened nails, elongated nails, it seemed to be a big issue. They're very common in those. The next big things were corns and calluses, and then fungal infections. All the others were there and were sort of changes in, as expected and as discussed today, in aging. Orthopedic issues were things like deformities, like the hammered toes, mallet toes, and bunions. So those were the 3 most structural things. And then other lesser toe deformities and flat feet took up another precedence there. Pain and tenderness, they generally found there was often pain in the ankle joints, tenderness on palpation of a site, so they felt pain when you touched them and pulled and pinched. Tenderness of the met joints, that seemed to be another one, and that would be in line with losing of fibrofatty padding. So that gives you a little overview, just looking at what sort of things are being affected in the population today. Another area is footwear characterizations and foot problems in older people. So Hilton's study here back in 2005 is quite good. His objective was to examine the relationship of footwear characteristics and the prevalence of these forefoot problems in older people. And he looked at basically foot pain and deformity in 176 patients, aged between 62 and 96, residing in retirement village using questionnaire and clinical assessment. Results: most participants wore shoes narrower than their feet. Women wore shoes that were shorter, narrower, and reduced total areas compared to their feet than men, wearing shoes with heel elevation greater than 2.5 millimeters or 2.5 inches 25 millimeters was associated with hallux valgus and plantar calluses in women. So this is that typical tracing of the foot and the shoe that they would be wearing. And you can see that foot shape does not fit that shoe. And the differences. So you can see a lot of negative numbers, which basically show all the differences, showing where the shoes were smaller, and pretty much a lot of the shoes that they wore were incorrect and not of the right size. Here are a few other studies which you can review, which will also address similar areas and changes that happen in people's feet as they get older. And then there's one study I found, which I thought was quite interesting. Historically, research on the skin is all on the base of postural stability by the sole of the foot. And this area is in contact with the ground as we stand and move, and special receptors from the sole of the foot provide information that contacts pressure and slips the foot with a known decline receptor feedback with age. Recent research has shown that the skin on top of the foot may be equally important in providing movement feedback. It tells us about foot contact with obstacles during walking. Moreover, removal of the feedback from the skin area affects our ability to position our ankle in space and changes how we can walk over obstacles. So the study was carried out by Mildren in 2017 and tested to see the skin sensitivity from the top of the lower leg and the top of the foot affected by aging. There were 12 young and 13 older adults responding to light touch and vibration inputs on various locations on the foot, of the leg and top of the foot. Touch sensitivity, the level of input required for perception, was assessed with thin filaments on the front of the foot, leg and foot. The tools are known to target a type of receptor called fast adapting receptor that fires the responses to contact and velocity input. Findings from the severity test were then related to an overall functional task on the standing, reach and gait. Outcomes. Result showed that the older adults had thresholds that were 5.5 times higher than young adults across the various sites tested and the legs and top of the foot. Thus, older adults needed more input to feel the touch. To further understand which type of skin receptors were most affected, vibrations were tested at different frequencies, 3 Hertz, 15 and 40. The greatest deficits in sensory perception were found at 40 in the older adults, where thresholds were found to be increased in older adults across the 4 most affected sites. A 400% increase in threshold, decrease in sensitivity. Vibration of 40 Hertz, similar to the filaments, are known to be target fast adapting receptors. Finally, the changes in skin sensitivity correlated with functional tasks. Both the timed up and go tasks and the functional reach tasks were effective, most in individuals who had the greatest decline in sensory input. So what was seen? An increased sensitivity threshold in both monofilaments and 40 Hertz vibration in older adults, which points to deficits in fast adapting receptors, a class of receptors that is in abundance in the foot, sole and dorsum. The receptors have strong connections with muscles of the lower limb and are used to generate reflex responses, as well as generate muscle activity for everyday movement. The decline in sensitivity is believed to reflect and reduce presence and ability of these receptors to contribute functionally to daily tasks. This is meaningful because, along with other sensory and strength disciplines that come with age. Reduced sensitivity in this region may reduce the ability to properly position the foot above the ground and the potential risk of safe ambulation. So that ends my lecture for today. I'd like to thank Stephen and Debbie for their help with material for this talk, and if there's any questions.
Thanks very much, Tarek. It just goes to show what a really broad area gerontology actually is to cover for the podiatrist. And I guess from my perspective, Tarek, based on your clinical practice, I'm just wondering a little bit about some of the more common musculoskeletal foot problems that you manage with your client base. And I'm wondering if you can comment on that, Tarek, in terms of what you see and how you handle it, musculoskeletal, that is.
Sure. Look, my MSK stuff ranges, well, let me start. One of my areas of work is in an MSK unit with an MSK doctor, a physio, myself, special nurse practitioners, and massage therapists and nutritional dietitians. And it's very interesting when these patients come to us, they tend to have a vast range of changes taking place. And so they may well come to me, or they may come to the doctors because they've got back pain and so on. But actually, when they've been assessed by the doctor and they've been sent to me, their feet have clear signs of hallux valgus, bunions. They're flat-footed, predominantly. They'll have hammered toes, and they'll often complain of plantar fasciitis or foot pain. So with that, the management per se is to help change the gait. Now, one of the big things that we as podiatrists always look at is, let's make them an orthotic and that will do the job. Often that's not the way forward. So what we've got to try and address is look at their pain. So if they've got a painful area, we can use material like semi-compressed felt, redistribute pressure away from that area where they're getting their pains. We can often, rather than making an orthotic, modify their shoes. Elderly people do not want to use a thick, hard orthotic in their shoe. They won't ever use it. They can't get them in their shoes. So often the most comfortable way of managing them is you take a valgus fuller pad. So we take a felt pad, say 5 millimeters, we cut an oval, and we'll stick it into the arch of their shoe. And you'll find that patient instantly will have relief, because not only will it lift their foot and their arch, it'll take the pressure away from the ball of the foot, it'll stop them overpronating. It will also help the pressure on their knees and their lower back because, again, this pull on them is reduced. And then what we would want to do next with them is see if we can help with the pain. Now, they're seeing the doctors. They may well be given steroids. They may be given painkillers. They may be given injections. But from my point of view, there's certain things that you can get your patient to do. And one of the best things is get them to soak their feet in warm salt water. Salt water is amazing. It's anti-inflammatory, it's relaxing. So if they sit in a bowl of warm water, putting their feet in a bowl of warm water for 10 minutes, tablespoon of salt ordinary salt. They can use Epsom salt, which has magnesium sulfate in it, which is good on circulation because it opens up blood vessels. That will help with their general aches and pains. And then some exercises. What we want to do is they're never going to have perfectly straight feet. So whether they've got flat feet, they've got their bunions, we've got to try and readdress their subtalar joint and their arches. And the best way is I get them to take a piece of tissue paper, kitchen paper, or a hand towel. I get them to stand on it. And then with their toes, they grip the paper. And what's happening there is you're working the intrinsic and extrinsic muscles of the feet. Now, that will address that issue. The second exercise I get them all to do is stand facing a wall and going up onto tiptoe and holding that position for 2 minutes. Now, it can be troublesome because if they're already unsteady on their feet, they might not be able to do a 2-minute duration. They can do blocks of 30 seconds and then come back and go up. Now, the difference there is you're addressing different muscles. Now, a lot of people go to a podiatrist or a physio and they'll give them calf stretches, which is great. They're all the superficial muscle, big body and bulk of muscle. But I want to target something different. I want to target flexor digitorum longus. So the deep plant muscles, which go from the back of your leg, below the popliteal fossa, down through the ankle and finishes in the ball of the foot. It has much more of an effect on the toes and the interossei. It has an effect on the arch, the metatarsal area and the plantar fascia. It has effect on the Achilles tendon, so all the superficial as well as the deep muscles, all the way into the leg. Now, one of the things I do with my patients is I often have a bet with them. And the bet is I guarantee that no matter how flat their feet and how bad their foot is, they can improve the shape of their foot. And how we do this is we get them to stand there and we trace around a piece of cardboard, and that is day 0. Now, I have that up in their wall. And then I say is every month, do the same, because you're doing your exercising, you're doing your salt water, you've got your cushion padding in your shoes. And often I will also tell them to use some sort of emollient, whatever they have. Things like coconut, baby oil, they're all really useful. They can use that, which will actually aid with circulation and help the quality of the skin. And then they'll come back 3 months later for a review and we'll do the same thing. And there will be a difference. The foot isn't as wide as it should be. It's slightly narrower, slightly shorter. So you're not going to cure them, but you can actually make a significant difference, which means that patient can now walk, still got a horrible looking foot, they're not in as much pain, and their mobility is improved. They can walk to the end of the road and get a newspaper every day or a loaf of bread, rather than say, I just can't do this. So you're improving their general well-being.
Okay, well, that's actually a really timely answer, because we've got a question from one of our students, Jason, and he's asked if there's any information on exercises for intrinsic foot muscles and what the benefits are. And he's also asking about exercises for the elderly in that context, Tarek. So you started to, answer along those lines, I think.
Yeah. I mean, the ones that I do, they're the ones that we've developed. But I think there are many guises to the same type of exercise program. The elderly can do exactly the same exercises as younger people do, but obviously you have to look at them individually because of the risks of osteoporosis, fracturing, and so on. And, it's how they do exercises, where they do exercises. The last thing you want to do is an elderly person with osteoporosis standing on a firm, hard surface and going up on tiptoe. The likelihood of a fracture is quite high. So the two I've mentioned are two good ones for them to do. It's kind of universal and can be used across all age groups. Other exercise programs that I guess physios tend to use. I work with a chap here in Sydney who is a foot physio. He specialises, a doctor of physiotherapy, specialises in foot, and he has a broad range of different exercises which, are accessible and can be reached, focusing on the different types of needs as we get older. For me, keeping things simple is the way forward. So the gripping of the tissue paper can also be done using a canned drink, for instance. If rolling your foot on a canned drink, that does the same job. It will help with muscle tone and stretching. Also, if the sole of the foot is hurting and is painful, sticking that drink into a freezer first, so it's icy cold, and then rolling will help with soft tissue inflammation as well, and help with pain. But yeah, to me, there are simple interactions that one can use. The ones that I use are probably the most commonest one, but you would have to see a physio literature to actually find specific ones that are used in the elderly. But the ones that I use pretty much are those two that I've talked about.
Well, Jason, I'll certainly get some of that information to you that Tarek's referred to, and I'll make it available on our views site. So Tarek, some other question that I've got as well is just in terms of dermatology, and I thought that the guidelines that you shared with us, just in terms of the management of the elderly, I think it's really valuable, and I'll certainly make that available to the students as a learning resource. But Tarek, what I'm thinking about is you did make brief reference to the use of emollients. You stated coconut oil as being a really good emollient for older patients. Are there any kind of suggestions that you've got in terms of emollients we can recommend to patients that are older for helping maintain the skin health status of the lower limb and the foot?
Absolutely. So think of first emollients in 3 different categories. So creams, oils, ointments. And the general rule is creams are easy to absorb, but they are drying. They don't last for a long period of time in the skin. Oils are generally better and they're easier to absorb. And then ointments are there where a lot of hydration is required and you want to seal in because they're thick and waxy and so on. So if someone is just getting old and just wants to keep their well-being good, then a cream or an oil is the way to approach this. So most moisturizers, things that you would readily buy in supermarkets and so on, the normal brands that are out there, they're all fine. But soon as your changes start applying to your skin and you start to get more dry, then using things like urea based in that cream or in that ointment is more prevalent. And the reason is urea is a good form of hydration. It has a chemical way of getting more moisture to an area. And we see this in things like heel cracks and dry skin. So using something like 10% is fine as a general cream or ointment, but as there are more deeper cracks and fissuring taking place, you really need to up the ante and be nearer the 25-30% of urea. Because if you go too far, like 40%, it will take off a nail. It will just destroy and break down all the appendages and proteins and enzymes. Whereas if you have that level, you're able to hydrate enough, and there are many preparations that you can get over the pharmacies like heel crack cream, Flexitol, Eucerin cream. These are all very commonly found and will have urea in them. A lot of people today tend to like a more natural, more holistic lifestyle, and they tend to like using different emollients which are readily available. Coconut oil, as I've mentioned, is something which is doing the rounds and is safe and is good to use. Other oil bases, when I was at university, olive oil was the thing that we were always told to use because it was there and local. Baby oil is what I tend to suggest to most people, especially the elderly. I think if you're focusing on a particular age group, you want the ability to have things which are easy access. So if they walk into Wally's or they walk into a pharmacy, you can get creams which are very expensive, but actually are they going to be that much more superior than a simple cream? We know that there's a host of creams on the shelf by different manufacturers, but a general moisturizing cream is all you need. An aqueous cream base with other things enriching are fine, but an aqueous cream base level is all you need. When you've got conditions where the skin is very dry, that's where you need more hydration. So as I said, an oil is better, or actually using something like an ointment, which is basically a petroleum jelly Vaseline base, which will seal in an action and keep the moisture for a longer period of time.
Okay, thank you, Tarek. Yeah, no, certainly does. And just make, with reference to the dermatological conditions, do you think that aging is associated with an increased frequency of any dermatological conditions? The one that's at the top of my mind is, for instance, eczema craquelle. It's much more likely to be seen in the elderly. than it is in any of than younger patient populations, for instance? Are there any other dermatological conditions which are more common with increasing age, do you think?
Yes, quite a few. I mean, I think for me, psoriasis is one that we see as your skin as you get older, your skin loses as its elasticity, its minerals, and so on. There's more widespread movement of a plaque, and so recovery isn't as good. Most of the eczemas as well. I think in my first lecture we talked about dermatitis and atopic eczemas. Well, they're not a problem. They tend to disappear as you get older. But all the eczemas, like the ones we talked about with circulation, the vascular eczemas, their varicose eczemas increase with age because there's an underlying circulation problem. So healing is the difficult problem, and then the irritation to it becomes a continuous cycle, trying to deal with the itch and heal, but also then manage the circulation and so on as well. So yeah, I think those probably are two main things I would say with aging reasons would be there, but pretty much everything gets worse with age. Everything rubs, everything doesn't recover quickly enough, therefore anything you have isn't likely to disappear as you get older, or just probably get worse or remain at a severe point. I can totally appreciate that, Tarek. And one of the things that I tried to get across to students with a tutorial in the first week was just how dermatological conditions in terms of the presentation can actually change with age. So for instance, many dermatological conditions in the elderly look very different in appearance than the same dermatological conditions in younger patients. So there's so many factors behind how certain dermatological conditions can actually present. And I wonder what your thoughts are in terms of the elderly, Tarek. Yeah, absolutely. So you're absolutely right. You will see pigmentations which you would think in a younger person is this, and then in an older person, it's completely different, but same pathology. They tend to be in different places. So in elderly patients, we find that if there is something presenting which should be somewhere else, it's there because of the way their skin has now changed, where the weakness in the skin has sort of changed the dynamic for it to manifest. I think I find looking at the elderly patients that I see, especially seeing things like little nevi, which I would have, or skin spots, or skin tags, they look in younger people as common areas like superficial, but in elderly they're quite deep. They're often mistaken for other things because they can be melanomas, they can be skin cancers. I think, that probably is how I would assess that. It is more prominent not to just look at something on face value and take an image, take a picture, look under a microscope, and then re-examine whether that lesion is what it is.
Okay. Thanks very much, Tarek. I don't think that anyone else has got any questions to bring up. Nothing from the lecture theatre here. Tarek, I really appreciate the time you've taken with this lecture today, and just the overview that you provided over, what is just a really complex area. I think it's a fantastic introduction that we'll build on for the remainder of the unit, Tarek. So, once again, thank you for your time, and I'll be in touch.
Pleasure. Have a good night. Thank you very much for listening.
All right. Thank you, Tarek. Bye.